So today we have Nellie Darling agreeing to talk with us today. And she's currently a fourth year medical student, but she's actually had quite an extensive career before this in public health. And it looks like it goes back to 2013 when she was at the Fairfax County Health Department. But from 2014 until 2017, she was at the Department of Defense. And she'll probably tell us a little bit about what she did there, but largely working in public health and epidemiology is my understanding, correct?
Yep.
And then most recently, she's assistant public health officer on the Georgetown University's COVID-19 response team. She's also going to be arranging an elective for the rising fourth year medical students in COVID-19 and around preparedness and public health. And so I think it's a great honor to have her today to talk to us about this and how we open in a rational manner from COVID-19.
The kind of public health I worked in, predominantly infectious disease and a lot of disaster planning. When I was at the Department of Defense, I worked on Ebola, Zika, and MERS-CoV. So dealing with coronaviruses, particularly within the military, and how to be prepared for that sort of thing has been a large part of my expertise. So I'm helping right now respond to the COVID-19 pandemic within Georgetown and dealing with a lot of contact tracing and helping us create guidance for how to reopen safely as a university in the fall. So let's get started with where we are today. I start with this big, beautiful map because A, it's a lovely image from WHO, but B, because it doesn't really tell us a lot. It's very easy to see that there are cases in lots of places, but in terms of, making decisions, this is not a particularly helpful map. So let me break it down a little farther. This is from IHME, which is the modeling group out of University of Washington that our current administration is using to make a lot of policy decisions. So let's use that as kind of the starting point. On this particular graph, you can see confirmed infections as well as current tests that are being done, as well as some projections and some clouds of uncertainty, if you will, around those projections. What I want to point out here is this is cumulative data, and it has policy predictions on the same graph. I also want to point out that with tests, which is our blue line here, that's been aggregated for the entire United States, and a lot of states report testing differently. So while it's easy to look at this graph and think, oh, tests are going up, confirmed infections are going down, that may not be the whole story. And for example, in the state of Virginia, when they report numbers of tests, sometimes that's individuals tested, sometimes that's samples tested, sometimes that's antigen testing, and sometimes that's antibody testing. So if you think about that as one big pile of test numbers, it can easily be confusing because when you look at a graph like this, your first instinct is to say, oh, every positive test means a new infectious person, when really that may not be the case. So this is a quote from our president recently, and I'd like to point out this is a true statement that if we do more testing, we'll find more cases. What's interesting is that's not reflected in this model. So if you look at the kind of policy projection of how many more tests are going to be completed, as an epidemiologist, you would expect to then see an artifact of the number of confirmed infections that are then reported as a result of those recently run tests. That is not kind of shown here, which I think is interesting to point out. So if we break this down even further and use a 5-day moving average for cases reported by day, this kind of gives us a feel for a real incidence as opposed to a cumulative average. So what you see here, initially is that the US is having a lot of cases, but also you see the kind of seesawing effect on the y-axis there. That tells me as an epidemiologist, this is still a propagated outbreak, not a point source outbreak that has a nice kind of peak and trough, as opposed to propagated outbreak where there's continuing community transmission. Now, these little peaks and troughs that we're seeing with our seesaw could mean a couple of things, and it's hard to know from this graph, but it could be related to the way people are seeking care. Commonly that people don't seek to go to the hospital on the weekends and don't seek testing then, so you'll see kind of a weekly surge starting on Mondays. Similarly, a lot of labs don't report their test data until Monday. So some of this could be artifact and some of it could be indicating continued transmission. This is a quote from Dr. Fauci recently, and I think in seeing this graph as opposed to the one before, you can see where he's coming from, that yes, we're going in the right direction, but we still have a long way to go. So perhaps a more useful indicator about how to make reopening decisions is hospital utilization. And what I'd like to point out here, this is the same IHME model, which shows beds needed and ventilators needed. And I'd like to just point out this very large cloud of uncertainty around beds. And this aligns nicely with kind of the first week of May. And what it says to me is that we really don't know what reopening is going to do to our healthcare capacity. We're not sure if we're ready to handle it or not. I think perhaps moving forward, given the confusion around what cases mean and what tests mean as far as dates and data, that this might be a more useful indicator as we move forward. And the last kind of piece of the puzzle for our current situation is our death count. And this is a pretty straightforward graph. I just want to articulate one point here at the bottom, that this week, if we continue on the progression that we have been on, that we will have more confirmed deaths in the United States than the entire case count in China. And that is, I think, important to mention just because it's easy to get kind of news fatigue and forget that there are kind of the magnitude of what's happening. Oh, now I see a chat. Did I need to, something going on? Oh, thank you, Dr. Belton. Yes, that's a great point in terms of what's available. And I think that this is a national model. It's not necessarily reflective of local, county, and state updates, which perhaps are being shown. So this is a great point that it's not just a static number. It is very much a dynamic piece of the puzzle. Thank you. All right, so moving on to talking about reopening. I would like to point out first that this is not a battle of human survival versus economic survival, although it may look that way when you look at the numbers. I think I speak for most epidemiologists and public health folks when I say everyone would like to reopen, just that the public health folks want to reopen once. We want to reopen one time and we want to stay open. So how do we do that thoughtfully and sustainably when we have an economic situation that looks like this? And if that's kind of hard to wrap your mind around, then here's kind of the situation with meat products in the United States, where we have essentially halved production and prices have gone up significantly. So let's go back to a bubonic plague outbreak in San Francisco in the US in early 1900. I start with this because I think it's important to showcase limits and kind of the extent of what public health should do and what it shouldn't do. So many of you may not have heard of this outbreak. It started in Chinatown in San Francisco in an immigrant who was from China. Interestingly, he had immigrated about 10 or 11 years before the outbreak started, although the outbreak was very much blamed on immigrants and their recent status as coming from China. The public health department in San Francisco decided to institute a quarantine without explaining to the local neighborhood what was going on. Obviously, this was not very well received. Interestingly, there were kind of similar issues that we see today about the public arguing about the veracity of the diagnosis. There were a number of kind of comparable turns of phrase that have been used since, kind of this idea of an indefinite lockdown, which no one really likes that sound of that, but trying to figure out how do you proceed when you know you haven't gotten rid of the source of the infection. Now, back in 1900, the source was thought to be these particular folks in Chinatown as opposed to fleas. So as a result, some kind of aggressive policies were used that I think today we would very much consider racist. So how we continue and move forward, I think it's important to recognize that when we don't have enough science, our tendency as human beings is to look for a scapegoat. We often pick the wrong one. So let's try and make sure that we keep that in mind. I'd like to think that we have improved since then, but considering some of the issues in headlines recently, I'm not so sure. The guy here with the kind of large mustache, Dr. Kenyon ultimately went on to found NIH. Right, so moving on to another coronavirus that many of you have heard of, I'd like to just recap a little bit about SARS. So I have kind of the cases and deaths up here on the top. And what I want to point out is some big lessons learned that we gathered from this are that kind of the 80-20 rule about epidemiology, that 80% of the cases in an outbreak are often caused by 20% of the individuals. So what does this mean? And it gets to the idea of super spreaders. And I have to say, I don't love that word because as an epidemiologist, it's not a very clear-cut definition what that means, because it could be that some people are inherently more infectious, as we saw with SARS-CoV, and that your individual R naught or reproduction interval could be greater than the average of a population, and so that could skew your data. So it could be that certain individuals are more infectious inherently, or it could be that those individuals are doing things with their behavior that cause them to come into contact with more individuals and therefore spread the disease. So it could be one or the other. What we saw with SARS, this was a large part of the kind of the game there. And what that says to me is that we can't forget the importance of contact tracing, especially when we could, help find those 20% and help them either change their behavior or make sure that they stay away from, the other population. The other 2 points I want to make here are that it's easy to kind of assume with all coronaviruses that the lessons are the same. Some of them aren't. With SARS, we saw a lot of healthcare workers that got infected, particularly in Canada. And this had to do with kind of confusing messaging about how to use precautions, particularly early on, and particularly with airway manipulation, similar to what we're seeing now. What's different, though, and this was a confusing point in the beginning of COVID-19, is that with SARS, as many of you know, the transmission only occurs once you see symptoms. That's only when you become infectious, after symptom onset. And that is not the case with coronavirus 19. We're seeing that 2 days prior to symptom onset through the first day after symptom onset is when you are most infectious. So just a reminder to not lump all coronaviruses together. Similarly, this is an area of expertise of mine. So with MERS-CoV, the Middle East respiratory coronavirus, which is a little bit more current than the SARS example, I bring up a study that's near and dear to my heart about kind of making sure that we don't make assumptions about the type of transmission that's happening. So this graphic here showcases the incidence by date on the bottom with the red and green, and then these kind of large blocks of gray above them. And essentially what each block of gray indicates is a nosocomial cluster. And what had been previously reported in the literature is that MERS-CoV was a seasonal disease, particularly increased transmission in the spring related to camel breeding season. However, our team looked at this a little more closely with data and was able to show that actually nosocomial transmission lined up with these particular increases in incidence. So I think I want to point out that it's easy to assume with incomplete data that there may be a causation there that really isn't. And then the second point I want to make with MERS-CoV is this kind of sub-outbreak, if you will, in 2015, where MERS was carried into South Korea, or the Republic of Korea. And I just really think this is a stunning graphic, and it helps underlay the same ideas that you still have super spreaders and that the importance of contact tracing cannot be overstated. I think with COVID-19, I've heard a lot of folks say, well, what's the point? The transmission is so widespread. How does that help? And I go back to that 80-20 rule, which we're not quite sure if there are super spreaders for COVID-19 or not. I think we certainly know that the isolation and quarantine efforts, social distancing, have not been consistently implemented or consistently followed across states. So there's certainly a behavioral element there as well. All right, so moving on to 1918, I want to talk a little bit about Spanish flu. So this particular pandemic affected a third of the world's population. It affected more people in a year than the Black Death had affected in a century. Interestingly, it affected predominantly young people, which is different from what we see with seasonal flu, where it affects predominantly the older folks and the kids. Interestingly, if you think about what was going on in the world in 1918, with World War I, that young folks were, those in the military who were traveling the most, so there may be a connection there. And And also this graph I have here shows the weekly excess death rate, which is kind of an odd measure. So let me just explain that real quick. This study looked at the incidence of death related to Spanish flu in the time period of the outbreak in the United States. And the excess death really was that they took total deaths and subtracted the baseline amount of expected influenza or pneumonia deaths for that time of year. So that gives us kind of a better indication of which deaths were really related to Spanish flu, because back then the way we recorded death certificates was a little different. So what we can see from this graph is that there was definitely a second wave. And in the United States, it was not as large as the first wave, but in the rest of the world, it was considerably larger and considerably more deadly. And we don't really know why that was. There have been some theories about the first wave. Perhaps maybe it wasn't taken seriously. A lot of folks considered it a joke and didn't wear their face masks or didn't observe kind of the social distancing measures. Actually, in San Francisco, if you didn't wear a face mask, you were fined. So I'd like to point out kind of some specific examples. Also, this little arrow highlights November 11th, which would have been Armistice Day. I think it's interesting to see what happens with kind of the death rate when you consider folks coming home from war. Perhaps there were parades, perhaps there were celebrations, and certainly increased travel that may have led to part of the reason we had a second wave. So now let's move on to two cities. And the classic example is this tale of two cities, of Philadelphia and St. Louis. So back in 1918, Philadelphia was one of the first places we saw a significant amount of cases. In the United States, the first cases were reported out of Kansas at Camp Funston. And in Philadelphia, there was a case or two, and then kind of this scheduled event of a welcome home parade for the troops. And Philadelphia chose not to cancel it and continue on as normal. Whereas the same day, St. Louis had a couple of cases and said, oh, no, we're going to kind of go big and go early, just kind of like New Zealand did now, and instituted a large amount of lockdown, if you will. And we can see kind of the evidence of that in these two graphs. I'd like to also point out something that you can see here pretty clearly is these double peaks, which I'll come back to. But essentially, this showcases that some cities were able to avoid that, and other cities were not. It's kind of an interesting issue. So this study out of JAMA looked at these non-pharmaceutical interventions, which is kind of a very long-winded public health way of saying social distancing, or banning school gatherings, or banning school closures or banning large gatherings. So those kind of three things encompass non-pharmaceutical interventions. And really, this study tried to evaluate, did they work? So here are two of their images from that. And in short, you can see that those cities that had a delayed response time, so a delayed activation of these non-pharmaceutical interventions, ultimately experienced more deaths on the whole. And also those who had these interventions for longer periods of time, a longer duration, incited fewer deaths as a result. So this is probably the most important slide I have in this deck, and I think it is particularly important that I point out a couple things. The non-pharmaceutical interventions are what we'll consider social distancing. The most important things about that are, when did they turn on? How long were they on for? Did they use a combination? So the study kind of picked out 4 cities that were kind of unique, if you will, in how they went about that and what went well and what didn't. So let's start with image C here with Denver. This is perhaps the best one of the bunch, if you will. You can see that they had at the bottom with the large black bars here, this is the interventions that they instituted. And I know it's a little bit small on the screen, but essentially you can see that there's a break in the bars, and that they instituted a number of these interventions, got cases down, and then said, okay, let's reopen. Started to see cases increase, immediately put those interventions back in place. So to me, this shows that they were responsive to what was going on and adaptable, because St. Louis had kind of the same issue, but Denver actually instituted new NPIs, if you will, new interventions. They started doing isolation and quarantine. And together, by being flexible about the combination, they were able to squash their incidents. Now, if we look at New York City and Pittsburgh, these both did the same thing. They ultimately got their incidence rates down. But what I want to point out is by doing kind of these delayed interventions, their peaks were higher and the peak was not delayed. By kind of breaking up the interventions and helping to close schools and ban public gatherings, there was a delay in the attack rate, which essentially allowed the healthcare capacity to withstand the increase in cases. Whereas in New York and Pittsburgh, it was a much bigger deal and ultimately saw a greater increase in deaths, as you can see here. All right. So to wrap up on 1918, I think what the big takeaways are that individuals want to adopt what they see as effective in society. So if there's data available and people are managing, the expectations about what is success, then they'll adopt those procedures. But we need to be transparent with the folks that we're trying to institute, social distancing, why we're doing it, and how long we're going to be doing it for. We saw that with San Francisco Bubonic Plague as well, that when you're honest with the public, you can increase the trust. The other thing is here that the cities that had interventions in place ultimately did not see a second wave. So let me go back one slide here. So New York and Pittsburgh, while they had a larger death count, by extending their interventions over a long period of time, they were able to avoid seeing that second wave, which is an interesting point as well. So the big takeaway from this study was that early, sustained, and layered approaches for social distancing are the most effective, at least in 1918. I'd also like to point out this image from Mr. Crosby, who's one of the authors on the forgotten pandemic, which gets a little bit at cultural amnesia. Perhaps it was the fact that there were other events in 1918, like the war, that eclipsed this pandemic, but it was hard to find a lot of data on it because there were other things going on at the time that were significantly more important in society's mind. So a lot of the lessons learned are lost to history for this. So let's come back to today. What can we learn about other countries that have already started to reopen? How are they doing? So if we look at the first place where this started back in Wuhan, we know that they, had very strict lockdown procedures and essentially have started to reopen since having no cases for a month. But now they have a new cluster. And interestingly, it's in a residential living facility, like a nursing home. And the majority of cases in that cluster are asymptomatic. What we're seeing in New Zealand is that they did kind of a very successful job about, I hate to use the word eradicate, they did they're very successful in getting rid of cases. Now we're seeing kind of sporadic entry-level cases of cases coming from other countries into New Zealand. But they've essentially gotten rid of community transmission. With Germany, we're seeing some kind of increase in the R0 value. So this is a bit technical. So what I'm trying to get at is, as the weather gets nice and people go outside, the behavior that people are choosing means that the reproductive value goes up. And that is, the case with influenza. The seasonal influenza R0 is about 1.5. So this is not necessarily a deal breaker, but it is important to note that as people start to move around, the behavior changes the R0 value. I bring up the Republic of Korea or South Korea because they started to have cases around the same time as the US. They recently shut down and opened again. And as a result, they saw a new cluster. This younger kind of group all started with one person who went to a nightclub, and then recently they've found 54 cases, related to that one individual. So going back to the idea of a possible super spreader who may or may not have been asymptomatic. The other issue I bring up here is Sweden, because I think that's been a controversial approach. And they've kind of gone ahead with the herd immunity goal, which I think in most countries the goal initially was to avoid incidents. Now, Sweden had some legal issues where they were not actually able to institute a lockdown as opposed to the rest of Scandinavia. So as a result, they kind of took on this herd immunity approach, which is an interesting gamble, if you will, because we don't really necessarily know how long immunity will last for. So in some ways, they may fare better during what we know will be the inevitable second wave now that we're reopening. But how long will that immunity last? Will it enable them to outlast the second wave? I'm not sure. We'll just have to wait and see. So now I'm kind of transitioning back to today. And this is a model out of Colombia that looked at that R naught value that we were talking about in each state that is planning to reopen. And this particular image looks at each county within each state. And I bring this up just to show that it's easy to look at that aggregated data and think that's it. There's nothing more to it. And really, each county should be making kind of individual decisions for itself about how to reopen and whether or not there needs to be kind of a cyclic, maybe they reopen for a bit and then goes back down. So that's kind of the point of this slide, is that each county is, in fact, its own entity here. And I think this graph perhaps is better understood when compared each state to other countries that have reopened. And kind of this green box in the lower left is kind of the ideal situation, that we have a lot of places that are trying to reopen when they're not ready. And that's dangerous. So the same model projected out what would happen in each of the reopening states versus the states that are choosing not to reopen. And while it's not necessarily important what each state has on this image, I show it just to indicate that on the right-hand side, even in states that still have some of the strict precautions in place, we still have continued increases in cases and continued community transmission. This is kind of the aggregate model for both the restricted and the opening states at the same time, which shows that when you have anybody reopening in the country, that ultimately that will lead to more travel and ultimately an increase everywhere. So what do we do with this information? How do we move forward? So one of the ideas that is a foundational principle in epidemiology is that you need to test, treat, and trace individuals. And this seems easy to say, and it has kind of a nice alliteration to it. But what's important here is that we may be testing, but not all tests are the same. You all know this as well as I do, that the sensitivity and specificity matter, and that when you have tests that have very different numbers for those, it's hard to make a comparison. It's also hard to say whether you're doing antibody or antigen testing, how to make decisions about data like that when you can't tell how many people in a population are still infectious or not. The other point here is that tracing, which I've mentioned a few times in this talk already, is a really important piece. It's very easy to overlook because it's the kind of boring bread and butter of public health, which most people think about, calling your former sexual partners when you have to report an STD piece of information, and it's not exactly something that most people want to think about following up on contact tracing. But that is kind of the critical way that we're able to squash transmission. And it's important when we're thinking about reopening, because we may need to deal with clusters and pockets of infection, and that's the way you respond to that. The other point is that the data we do collect from the testing and tracing, we need to act on it. And as Dr. Welton pointed out earlier with the ventilators, that these models that we're using are inherently dynamic. They need to be updated, and that the public, this needs to be communicated to the public, that we may reopen today, but in 2 weeks we may close down again. And that's not necessarily a failure, it's just an adaptation. Last thing I want to mention here about moving forward is that we have to be ready to adapt. We saw this with Denver, with some of the other cities, that when things started to go south, they reinstituted their non-pharmaceutical interventions with great success. And I think we need to keep that in mind. The other point is, there are things coming that we haven't thought of yet, kind of the unknown unknowns. I've taken a guess at some of those unknowns here. There's a mounting pile of evidence that perhaps there is some aerosolization of COVID-19. I think we've seen enough journal articles that indicate there is aerosolization. The question that remains to be answered is there transmission as a result of that aerosolization? We know there's certainly contamination of surfaces. Whether or not the viral load in those aerosol droplets is sufficient to actually infect another person is still up for debate. The other idea about seasonality is certainly something we're all watching. I've included a quote here from one of the modelers at Harvard who's kind of big on the communicable disease modeling. And it's a possibility that we may kind of get some help here from the temperature. It's hardly something that we should rely on. Again, we'll just have to kind of see and adapt. We talked a little bit about what happens with Sweden and kind of trying to establish how long does immunity last? What does a kind of certificate of clearance or certificate of immunity mean? Our workplace is going to start requiring that to go back to work. Certainly been discussed. I don't necessarily know if that's the best way forward, especially if immunity only lasts 3 months and you can get it again. How do you move forward? Talked a little bit about the idea of periodic lockdowns or reinstituting kind of social distancing measures based on case counts and based on information. And I think this is, again, part of the messaging that needs to be communicated to the public, that this is a very real possibility. Just because we reopen does not necessarily mean we stay open. We have folks that are leapfrogging over the phases, if you will, in our policy guidance and kind of going straight to phase 3 as opposed to going through the phases outlined in the documents, which is problematic. And while the public health folks want to reopen one time and stay open, that may not necessarily happen as we've seen in 1918. So we need to be prepared for that switch. And then lastly, I mentioned here just some of the regular threats that we deal with on a day-to-day basis. We had a pretty mild winter, so there's talk of a very robust hurricane season, which if that aligns with when a second wave might hit to relay summer, could be problematic. Also, depending on when the second wave happens, may necessarily align with flu season. So trying to think about what capacity looks like in a hospital when you have regular flu cases as well as corona cases, and how to adapt our triage procedures accordingly. So I'll stop there. Thank you very much for your attention. I'm happy to take any questions. Thanks, Dr. Welton.
Hey, this is Al. I have a quick question. Has there been, great talk, by the way, sorry I missed the beginning. Has there been any sort of modelers in the US that have looked at the granular data surrounding recent holidays like Easter, and has that increased caseload in any of the US cities?
Yes, the short answer is yes. It depends on which cities and which models that we're talking about. I'm happy to send those along to the group after the talk, but essentially we expected to see a small uptick after St. Patrick's Day and after Easter, and that definitely happened. It happened in cities that were larger where there was more travel, and also kind of it aligns a little bit with the airline travel related to those holidays. Folks necessarily going to see family driving by car, taking all the right precautions and wearing masks. Not a huge risk for transmission, but if you're traveling a larger distance and going by plane, we've certainly seen that reflected in some of the case counts. I will say a small caveat with that a lot of the folks who traveled over spring break in college or, elsewhere during some of these holidays, a lot of those folks who are in the younger demographic have been asymptomatic, some of which have been able to get a test. So just because the test confirmed case number did go up, which we did see a mild increase after those holidays, I would caveat that and say there's probably a larger increase that we're not seeing reflected in that data as a result of kind of the asymptomatic increase.
I think that's been a particular challenge for me is trying to make or work with the whole team to make decisions about what to do next. As I look at our just immediate regional areas, DC, Maryland, and Virginia, where the daily number of tests that are positive has remained static or slightly climbing. Whereas we feel in the hospital like we've hit kind of a steady state and that we peaked in May. I can't reconcile those two things other than to say that there's a lot more testing going on and tests are much more readily available now.
So I would agree with that. And I think I know of a couple places that are starting to open testing centers that do not require a referral for a COVID-19, which was previously a requirement to get a test, was that your primary care doctor had to write you a referral. So without that roadblock, if you will, that will certainly make testing more available, probably not as widely available as we need to really evaluate community transmission. But you bring up a good point about the steady state that's been reached in hospitals, while the peak in DC necessarily hasn't been reached. So there is kind of a discrepancy there, that we're having increased cases in the district. So we haven't peaked here yet, but yet hospitals in the district are seeing kind of a tapering off or a plateauing. So in some ways that's encouraging, right? Because it means if there is a second wave, there's more capacity in the hospitals to deal with it. And I think that's why we're seeing so much progress with reopening, moving ahead, even though the data is spotty. I think you're right. Part of it is there's been more access to testing recently. And then kind of the second piece, that the folks who are seeking care, it's a smaller number, which is good.
Can I ask a question? This is Alex Montero. Can you hear me?
Yes, go ahead.
Yes.
The question I had relates to schools and reopening them. Any thoughts on, should we be giving guidance on things like UV lights for the top of the rooms, negative pressure for any of these rooms? Is there any thoughts about, I know these were used in the past, not the negative pressure, but the UV lights, not a new thought. Is anybody thinking about those kind of specific measures to help, regardless of when we do reopen the schools, as far as implementing them?
So yes, short answer is yes. CDC released some new guidance yesterday on reopening, which was a little bit more robust than the initially released guidance from the administration, which gets at some of those workplace interventions and recommendations. But to your point about school reopenings, and as someone who's helping craft some of that guidance right now, I can tell you that's absolutely something we're thinking about. The problem is with kind of the disinfecting UV lights and kind of the temperature screening approach is that, what do you do with folks who are asymptomatic? Do you screen them? I mean, what if they don't have a fever? Do you still let them on campus? And how do you approach folks that are not necessarily going to be picked up by that screening process? Now, to your point about disinfection, that's a really excellent point. I know those UV lights are predominantly sold to institutions in the healthcare setting, not necessarily schools, but it's certainly something we're thinking about. Oh, I see some chats here. Sorry, let me address some of those as well. Sorry, Dr. Montero, did that answer your question, or at least somewhat?
Yeah, absolutely. Yeah, thank you.
Sure. Will there be a Blue Angels, Bob? Oh, great question. I don't know, Dr. Walton. I'll have to get back to you on that one. Data from testing passports. I'm sorry, could you elaborate a little bit on what you mean by that?
Yeah, this is Al Vostel again. So they were talking about the apps that track, if you had a test,
Sure.
You're like green to go, yellow, you're waiting for a test, red, you're positive. Is there any data in the literature on that?
Not yet. I think we're still kind of waiting to see how that worked. I can tell you from my point of view, I know of patients who they're waiting for their test of clearance before their airline will let them on the plane. And I think there are other places that are requiring this documentation without kind of a full understanding of what that immunity means for them as either a passenger or a customer. So I know that's been in the conversation, but in terms of what's been publicly available from the testing passports, I haven't seen anything yet. I share your curiosity there. I look forward to seeing if that is useful or not. But as of right now, I don't know. We'll have to see. Oh, and Dr. Wilton, I see you have another question here about why do we not know by this time about the immunity question? Oh, that's a great one. I don't know. I would like
realistically, how many people in any region have gotten reinfected? And,
So two points to that. I think there's been some clouding of the data with reinfection. And I think part of that has to do with the quality of the test being utilized. We saw this with folks in Wuhan and elsewhere in China, where they would be positive, then have a couple tests that were negative, and then seemingly pop positive again, which at first glance, it looks like that could possibly be a reinfection, which is not off the table. But from the epidemiology perspective, to me, that says more likely the test was wrong those 2 times in between, and that it may be muddying the waters about helping us identify reinfection versus false negative. So I think that's part of the picture. How big a piece of the pie that is, I'm not sure, but I'm certain that that's part of the problem. And then the other piece about immunity is we don't necessarily have a great model. So with influenza, we know that, the influenza vaccine gives you a good solid 6 months of immunity, maybe longer. With coronaviruses, it really varies, because the common cold you can obviously get a couple times in a season, or maybe you get, a different subtype or a different species. And we've seen a lot of variation in the genetic makeup of this virus since it was first genotyped in Wuhan. So if you had the first strain, if you will, and then get exposed to, say, the 40th strain now, we don't necessarily know if there's cross immunity between those. There's likely some degree, but how much, we don't know, and that's kind of an evolving dynamic part of the problem as well.
Mhm.
Great question. All right, if there are no other questions, I'll stop there. Thanks, everyone.
Thank you. That was a tremendous, tremendous talk, and I really, really appreciate you sharing that with us and the work that you're doing for the university.
Oh, thanks.
Maybe we'll rope you into the residency decision-making task force
Yeah.
as an advisor, along with my amazing ID team that I have here.
Oh, I'd be happy to help.
Okay. Thank you, Nellie.